Hello and welcome to ACU's Hospital. Today we will be following Justin Smith, a 37-year-old man, over a 24-hour period. Shall we start? Okay, let's go. Welcome to the ward. Meet Justin Smith, who has recently been diagnosed with bowel cancer and needs an abdoperoneal resection. Now meet yourself, a young ACU student who needs to learn everything about your patient Justin. Well, looks like the doctor's here to take Justin for his procedure. We'll see you later, Justin. The time is now 8 a.m. and you need to pick up Justin from PACU. Welcome to PACU. Looks like Justin is awake, but what's the criteria for accepting him back into the general ward? Let's have a look at his observations. They look stable. Now let's take a look at that post-op criteria. Activity, voluntary movement of all four extremities similar to preoperative conditioning. Respirations, 12 to 25 breaths per minute, or if out of this range, plus or minus 10% of preoperative. Pulse, 60 to 100 beats per minute, or if out of this range, plus or minus 10% of preoperative. Blood pressure, 2 consecutive blood pressures 15 minutes apart, or if out of this range, plus or minus 20% of preoperative blood pressures taken. Oxygen saturations, greater than 96% on room air or with supplemental oxygen. Consciousness and mental status, appropriately responsive or unchanged from preoperative status. Pain score, greater than or less than 4 before discharge based on a 0 to 10 pain scale. Urine output, with indwelling Foley catheter, clear and adequate urine output. Any changes, no nausea or vomiting, anxiety or agitation, and no evidence of excessive bleeding. Okay, great. Looks like Justin is back on the surgical ward, and the time is now 9 a.m. Justin has been given a patient-controlled analgesia machine for his pain. So what assessments do we complete over the 24-hour period, and how do we monitor his PCA? Patients using a PCA machine are at risk of respiratory depression due to oversedation. Therefore, nurses must assess sedation score, pain score, and respiratory status frequently and at regular intervals. PCA data is also recorded during regular patient assessment. Information such as frequency of medication delivered, dosage, and attempts made during lockout must also be recorded. The first 24 hours post-surgery involves the continuation of patient recovery from the effects of anesthesia. During the post-operative period, nursing assessments are made every 15 to 30 minutes for the first 4 hours, every hour for the next 4 hours, then every 4 hours until discharge from the ward into a recovery unit. Nursing assessments include level of consciousness. Assessments based on the patient's reaction to verbal stimuli are performed. Vital signs. These include pulse, respiration, blood pressure, oxygen saturation, and temperature. Neurovascular observation. The patient's skin color, temperature, at or below surgical site, movement of limbs, and range of movement. Neurovascular observations are based on the detection and early prevention of circulatory problems. Pain scale and PCA data. The patient's reported pain is assessed on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain experienced by the patient. PCA data is also reported during the patient's assessment. This includes history, dosage, and attempts. Wound. The patient's surgical site and wound dressing are assessed for excessive bleeding and or abnormalities. Drain tubes and lines. Wound drainage. Catheter bags and IV lines are all observed for appropriate function and fluid height. This helps monitor fluid intake and may address problems experienced post-surgery. Considering Justin has a surgical drain, let's do some research on surgical drain. Surgical drain tubes are used in a variety of surgical procedures. They are thin, flexible tubes which are placed into surgical wounds to remove fluids such as blood, pus, and serous fluid to prevent buildup within the wound site and surrounding tissue. They may also be used to remove air from the site, especially in the case of abdominal surgery, when air is pumped into the abdominal cavity in order to increase visibility and maneuverability of the organ. Another purpose of drain tubes is to assist with the characterization of fluids that is being drained, which can allow early detection of post-operative complications such as hemorrhage and infection. In Justin's case, another serious complication with the drain tube is anastomach leakage, which is the leakage of digestive fluid into the peritoneal cavity. Nursing assessments on surgical drains include drain site assessment. Initial assessments include assessing the skin and tissues surrounding the drain tube for leakage, redness, and swelling. The condition of the site should be recorded in the patient's wound chart, and the site should be regularly reassessed for any changes. The surgical team should be notified immediately of any indications of infection such as increased redness, swelling, offensive odor, pus, and fever. Dressing. The drain tube dressing is applied during surgery and is usually not removed for the 24 hours following surgery. The dressing provides protection to the wound site and helps to absorb excess fluid from the site. Dressing should be closely monitored and changed as required. Patency. The drain must be assessed for patency and checked to ensure that there are no kinks in the line which could prevent fluid draining freely. Suction. If the drain uses wall suction, the settings should be checked against the order from the surgeon to ensure that they match. If the drain is negative pressure device, it should be checked to ensure that the suction is working. And output. The amount of output from the drain needs to be checked and documented at least every 4 hours, and the container emptied regularly. The color and consistency of the output also needs to be assessed and documented. Any concerns with the amount of quality of the drainage should be directed to the surgical team. A good acronym to use when draining output is COCA, which stands for Color, Odor, Consistency, and Amount. Well, great! The time is now 1 p.m. and you are preparing your progress notes. But first, you realize Justin has a newly formed stoma post-surgery. Let's look at some nursing assessments for a stoma. The newly formed stoma appears swollen, but swelling generally decreases over 2 to 3 weeks and can take as long as 6 weeks. Failure of swelling may indicate a problem, for example, a blockage. Stoma color. The stoma should appear red and similar color to the mucosal lining and appear slightly moist. Stoma size and shape. Most stomas protrude slightly from the abdomen. Ileostomy stomas are usually more spout-shaped to facilitate drainage of liquid stool, whilst colostomy stomas may sit flush with the skin as stool is more formed. Stoma bleeding. Slight bleeding initially when the stoma is touched is normal, but other bleeding should be reported. Status of peristomal skin. Any redness and irritation of peristomal skin should be noted. Transient redness after removal of adhesive is normal. Amount and type of feces. Assess the amount, color, odor, and consistency. Inspect for abnormalities such as pus or blood. Complaints of burning sensation under the skin may indicate skin breakdown. The presence of abdominal discomfort and distension also needs to be determined. And assess the patient's emotional status, especially strategies used to cope with changes such as body image, lifestyle, and sexual relationships. Normally, patients are seen by the stoma therapy nurse before the surgery. The SDN will counsel the patient in regards to anticipated surgical outcomes, recovery, and rehabilitation expectations. The SDN will also demonstrate ostomy appliances and offer other information on how to live with the stoma. They also refer the client to the Australian Council of Stoma Associations and stoma groups. The mission of these associations is to provide support services for ostomates and distribution of ostomy appliances and other accessories on behalf of the Australian government. Talking with another person who has gone through a similar experience may help the patient realize that he or she is not alone, and rehabilitation and return to normal activities of daily living is possible. The time is now 2:30 and it's nearly time to end your shift. But before you leave, let's find out about Justin's catheter and the complications of having it. Urinary tract or kidney infections. Approximately 10% of patients with an IDC would develop a urinary tract infection. Despite good hygiene and the use of sterile equipment, the introduction of an object into the body increases the risk of infection. If a UTI goes untreated for too long, it may develop into a kidney infection or even sepsis. Catheter-associated UTIs are known as CA UTIs. Urethral injury. Insertion and removal of the catheter can cause trauma to delicate tissues of the urethra. The risk is increased if there is insufficient lubrication applied to the catheter before insertion, or if the balloon is not completely deflated before removal. Urethral strictures. Following urethral injuries, scarring and inflammation can occur, which can cause a narrowing of the urethra, which is known as urethral stricture. Urethral strictures can make it difficult to insert catheters and cause difficulty urinating. Bladder spasm. The presence of the catheter in the bladder can cause it to spasm in an effort to expel the catheter. Medications can reduce the frequency and severity of spasms. Incrustations. Mineral deposits and debris from the urine can cause incrustations. Incrustations are usually on the inner surface of the catheter and can build up to obstruct catheter flow. They can also coat the balloon, making it hard to deflate. Incrustations is generally associated with long-term use, and the risks of it increase the longer the catheter is in situ. And finally, hemorrhage. If the urethra or the bladder is traumatized or punctured when in situ, hemorrhage could occur. Well, that's it from us, students. Looks like you know everything there is to know about PACU discharge criteria, post-op nursing assessments, surgical drains, stoma assessments, and catheter complications. Thanks for listening and have a great day.